Welcome, everyone. I have an action-packed panel here of people that I have met at conferences and kind of reached out to coldly on LinkedIn, and they have opened their arms to be willing to speak with me and teach along the way. So I'm still learning from them on this journey, but today we are here to talk about the big bang of digital interoperability, and that's TEFCA. And for those that may be new to our topic, we're looking at interoperability, that is the exchange of health information data and make use of that. So again, not just sending that information, but is it really being used on the other end by our clinicians, and how is that aiding in the care that we are providing to our patients? And so just a quick overall look. I know we're going to go into a little bit more from our panelists today, but kind of looking back as we think of the Big Bang, what could that be? Is that TEFCA? I know many of us are familiar with the 2009 American Recovery and Reinvestment Act, where you had high tech and meaningful use. And then we have 21st Century Cures Act, and where we have TEFCA. So there have been lots of things happening along that way. But 7 years after the 21st Century Cures Act in December, TEFCA has gone live. So we really want to see what exactly is TEFCA, what is going on, because still presently, there are still 52% of organizations that share health data with other organizations who lack the systems to actually receive them and make use of that. And we still have 35% of office-based physicians only using paper-based sharing of health information. So there's still a lot of work to be done, but we're really excited about where we are currently. And so today's speakers, I'll start off by reading their bios, and then we'll kind of break off into them individually. We have Zoe Barber from the Sequoia project. She has over a decade of experience dedicated to advancing health IT adoption, health information exchange, and interoperability. As a policy director for the Sequoia project, she directs the organization's policy initiatives in response to legislative and regulatory activities, shaping the health IT landscape, including information blocking, privacy, security, and patient access. She also leads policy development for the Sequoia project as the recognized coordinating entity for the HHS Office of the National Coordinator for Health Information Technology, 21st Century Cures Act, Trusted Exchange Framework and Common Agreement. Previously, she served as a senior policy advisor at the ONC on the nationwide Health Information Network initiatives and was the forefront of policy development for TEFCA, as well as the other Cures Act policies and regulations. So welcome, Zoe. And then we also have Dr. Matthew Eisenberg from Stanford University. He joined Stanford Healthcare in early 2013 as the Associate Chief Medical Information Officer for the enterprise. In his role at Stanford, Dr. Eisenberg focuses on interoperability and health information exchange, government and regulatory informatics and reporting, healthcare analytics for improvement, inpatient optimization, and other uses of the technology to meet our strategic initiatives. He is a board-certified pediatrician and certified in clinical informatics. He is a clinical assistant professor in the Stanford Center for Biomedical Informatics Research in the Department of Pediatrics at the Stanford University School of Medicine. He is also currently the chair of the eHealth Exchange Coordinating Committee, the network governance body, and serves as a board member on the Sequoia Project Board of Governors. So welcome, Dr. Eisenberg. We also have Tina Joros. She is the Vice President of Policy and Innovation at Veradigm, and she presents the company and industry associations and advocates for federal policy initiatives that benefit ambulatory physicians and providers, as well as other Veradigm customers. In addition, she is responsible for the Veradigm patent program and advancing innovation through patented technology. Prior to her role, she serves as the general manager of the Veradigm Network Partner Solutions portfolio and is responsible for a diverse array of solutions and programs, including Veradigm Connect for API connectivity to multiple EHRs, Diagnostic Orders and Results Network for laboratory and radiology orders, e-prescribing functionality for enterprise vendors, Registry Hub for connections with state and regional registries for immunizations, cancer, and surveillance reporting, and more. She's passionate about accelerating innovation in health technology and continuing to advance to a state where technology more robustly supports the early detection and prevention of disease. So welcome, Tina. And last but not least, we have Dr. Juanita Brigman. She's a licensed clinical social worker with a doctorate in educational leadership. She's the owner of Full Blossom Behavioral Health Consultants, a mental health private practice in Kennesaw, Georgia, and is an advocate for best practices around mental health care for women of color. She took on this latter role after her second oldest daughter, Monet, passed away on May 19, 2021. Monet's passing was the result of her obstetrician's medical team failing to give her the necessary medical interventions needed to save her life from a blood clot that resulted from her pregnancy and ended in a pulmonary embolism. Juanita's mission today is to ensure that the maternal health of women of color is administered equitably and equally with the same level of care, attention, and seriousness given to their white counterparts. Juanita's goal is to positively influence medical, social, and economic policies and practices that undermine timely healthcare intervention and that ultimately result in unfair treatment of women of color, leading to negative maternal outcomes. Juanita is a voice of the voiceless, an advocate for those who cannot advocate for themselves, and a mom who would never stop fighting on behalf of her daughter and grandchild so that other women do not suffer the same fate. Thank you. Welcome. And as you can tell, I mean, we have the best speakers that we could find. So I really appreciate everyone taking their time today. So we'll go ahead and jump into with Zoe. Give me 1 second just to transition my slides. But Zoe, let's see here. Apologies. All righty. So thank you. I think, can you see your slides okay, Zoe?
I can. Thank you so much. And can everybody hear me okay?
Yes, we can hear you. All righty. So I will drive for you. But again, for those that may be unfamiliar with our topic today, what is TEFCA and some of its foundational elements? And, can you provide us insights on the current state of implementation, the future state, and how it truly has evolved?
Yeah, thank you so much, Rebekah. Thank you, everybody, for having me here today. So my presentation starts at the 21st Century Cures Act passed in 2016, although I think others on this panel are going to go even further back in history to give you a little bit more context. But the 21st Century Cures Act directed the Health and Human Services and the Office of the National Coordinator for Health Information Technology to convene public and private stakeholders to develop or support a trusted exchange framework and common agreement among health information networks across the country. And this really came from several years of feedback that they had received from providers and health systems and electronic health record vendors, health information exchanges that were extremely frustrated that they were unable to connect to all of the organizations where they needed to send data, and that when they wanted to connect, they had to do so, on an individual basis, one by one, and it can be extremely resource intensive. So in response to that, if you go to the next slide, Congress directed ONC to develop this trusted exchange framework and common agreement, the goal of which would be to establish a universal floor and baseline for technical connectivity, to develop these minimum set of terms and conditions, legal terms and conditions, as well as technical specifications that all health information networks across the country could sign on to and voluntarily sign on to in order to facilitate and allow all of their networks to connect together and exchange data. So this, attempt to simplify connectivity, across the country, and really with the intention of allowing providers and health plans and other types of stakeholders, and especially individuals who, as we just heard, continue to struggle to access data, to allow those individuals also to have the ability to connect into one framework and have access to health information from a multitude of providers across the country. Next slide. So ONC began to develop this concept and this structure, and this wasn't the first attempt that the federal government had tried to do this. This wasn't their first rodeo, and in fact, several of the initiatives that had been spurred by the federal government and then taken on through the private sector. One of which you may be familiar with is called Care Equality, which is also a similar type of framework that connects in health information networks. So ONC really developed the TEFCA based on some of the existing industry initiatives that were out there today that had already been road tested and tried and true. But by adding sort of the additional stamp and support and collaboration with the federal government, that really, I think, has taken and continues to take TEFCA to sort of a new level that some of these other industry initiatives haven't been able to achieve. So the basic construct is that ONC, the federal agency, is really the ultimate decision maker. They define and direct the overall policy and governance requirements. But the recognized coordinating entity, which is the Sequoia project, has a contract with Health and Human Services with ONC to serve as the RCE to provide oversight and governance for the framework. So the RCE really both helps with ONC's partnership to develop the policy and the common agreement and the standard operating procedures that everybody signs on to, and then also to lead the operationalization, and oversight governance of the QHINs and the framework. And then, as you can see here, again, the idea is that each of these QHINs represents a diverse array of participants and sub-participants from across the country. And the QHINs really provide, services to their participants, as well as, establishing and connecting in with the baseline set of technical and policy legal terms and conditions. Next slide. So the TEFCA itself is made up of a bunch of different moving parts. I will say what the TEFCA is not is a technical network. Some people may call it, you may have heard it called as a network of networks, which is helpful to visualize. But in fact, TEFCA is not a network. There are no actual technologies or infrastructure that the recognized coordinating entity controls. Instead, it's really a framework of policies, legal terms and conditions that are found in our framework agreements, so the common agreement and flow down agreements, as well as a series of standard operating procedures that go into more depth on the terms in the framework agreement, and then the QHIN technical framework, which describes the technical specifications that each of the health information networks, each of the qualified health information networks have to comply with and adopt in order to connect to each other. And then we also have a set of terms and processes for QHINs that want to apply, or networks that want to apply to become a QHIN, and ensuring that they have the appropriate privacy and security and technical and governance functions in order to actually serve in the important role of a QHIN. We're also right now developing metrics to help to crystallize and evaluate how, as TEFCA is being adopted, how that network exchange is progressing. Next slide. So as I mentioned, this TEFCA really started development back in 2016, 2017 timeframe, and I was actually at ONC at that time, and I was lucky enough to be serving in a role in which I was able to help to lead and craft the development of the first few drafts of TEFCA. And so I can really firsthand tell you just how far it's come from this really abstract, more policy-driven document to where we are now, where we've actually accepted and onboarded several organizations, and we've gone live on the first version of the Common Agreement and the QHIN technical framework. And actually now we're working on an updated version of the Common Agreement and the QHIN technical framework to start bringing in more additional technologies and purposes for exchange and ways to exchange. Next slide. So this is just a little snapshot of our newly designated QHINs. We actually have 7 QHINs right now that have gone live. You can see that here. And we have several others that are currently in the testing and onboarding phase. Next slide. So those QHINs that you saw that are live today, they are exchanging for the purposes here that you see on the screen. These are called our exchange purposes, and they're the authorized reason for sharing information. So in our common agreement and our SOPs, our legal documents, we describe in great detail what each of these exchange purposes is, how they're defined. And in many cases, we have gone into significant detail on certain sub-use cases and sort of defined extra, additional parameters for those use cases. So we're really, really excited because we think there's a lot of opportunity for TEFCA to be able to move beyond just the sharing for treatment-based exchange, but also being able to adopt more use cases like healthcare operations, public health, and that individual access services use case being especially important to allow individuals to connect in and access their data. Next slide. This is just a quick illustration that you can look at on your own time, but just really shows a basic treatment scenario where you have, a PCP making a referral to a dermatologist. The PCP and dermatologist are both part of two different QHIN networks, but you can see that the PCP sends the information to their QHIN, who then routes that information to the appropriate QHIN and then all the way to the dermatologist at the end. Next slide. And this is another example for another way that exchange might work, which is based on a query or a request for information. So in this case, Hospital A is requesting information on a patient and sends out a request to find all the places that that patient's information might reside. And the QHINs then return medical records from their participants and sub-participants that have data on that patient. Next slide. So both of those exchange mechanisms and use cases that we walked through have the QHIN in the middle. But we're also really excited, I said, sort of our next evolution of TEFCA and our updated agreement and or proposed updated agreement and technical framework are also planning to allow exchange via HL7 FHIR-based APIs. And so we're working on now to enable support for participants to be able to connect directly with each other with those FHIR-based APIs. And then they would continue to use their QHINs to really scale support for that FHIR, so the QHINs will continue to provide trusted exchange services and record location directory services in order for to assist and sort of scale in that FHIR-based exchange. Next slide. So this just shows sort of where, kind of leaving off from the last timeline we showed, kind of where we're going next. We spent 2023, the better part of 2023, drafting updates for the Common Agreement version 2 and the QHIN Technical Framework version 2 to support that facilitated FHIR-based exchange, as well as other policy updates that were necessary. We have released those drafts for feedback. We have been engaging with stakeholders on an ongoing basis to get feedback on those drafts and working with our designated QHINs and their participants and sub-participants also to get feedback. We're actually moving into more of the, as we move into more of the operational phase, we are also establishing our governance processes, our formal governance processes. So the future work and future updates to the Common Agreement will go through more formal change management processes where we have representation from all of the stakeholders and all of the QHINs and then their stakeholder representatives that will be participating in the exchange of information. Next slide. And if you'd like to learn more, please visit our resource library at the sequoiaproject.org/RC resources. And we have several webinar events and materials and educational resources on there that you can look into more. Thank you so much.
Thank you so much, Zoe. Really appreciate that. And a large part of what we are doing here at Stanford is really to translate many of the policies that we see from the government level to something that, what is actually happening on the front lines. And so with that, we have Dr. Eisenberg. And so from the perspective, from your position. Tell us a little bit about the implementation of TEFCA for Stanford and kind of your readiness, and what does it look like having already been connected to other HIEs?
Thanks, Rebekah. Thanks, Zoe. Hopefully you can see my slides and hear me. Thanks for having me. It's incredible to be part of this really remarkable panel of incredibly knowledgeable folks. Zoe and I are on so many calls together. I can hear her voice even off of the calls, and I always learn something from Zoe. I've gotten to work with Tina most recently, and I'll tell you a little bit more about the tactics. But I'm going to go back, and we've already seen a couple of timeline slides, and happy Valentine's Day. I went back, so I think that the 2 points I really want to make here, and one Rebekah you already talked about, which the TEFCA really does live in this whole health IT environment. So the HITECH Act and meaningful use were really important starting points before we could even have TEFCA. So until the nation got onto electronic health records, it was pretty hard to conceive that. But if you actually go back to the Constitution, and we're talking about a national framework of interoperability, I just want to point out a couple of things. The Constitution does not contain the words health, healthcare, or medical care. Just so we're clear, it's not in there. And although we have some large, important federal payers, we actually have very, very precious few federal health delivery systems, apart from Veterans Administration, DoD, military health system, and then even large health organizations that want to share information. Healthcare is still in this country regulated at the state level, so we all have to be aware of state law, and that's important. So just an important sort of framework for some of the challenges that we're dealing with in terms of national interoperability is the Constitution still has healthcare regulated by the states. Zoe talked about how many changes there were to the drafts of TEFCA, and it keeps coming fast and furious. And that's also important to see all of those dots on the right-hand side. It's keeping us pretty busy. I first started talking about TEFCA when the Cures Act was passed, and I tried to tell people what it wasn't, because they weren't familiar with this concept of TEF. It's not Anna-TEFCA from Fiddler on the Roof. It's not Teflon. It has nothing to do with Teflon. It has nothing to do with DEF CON, and it's definitely not AFLAC. So it's TEFCA, Trusted Exchange Framework and Common Agreement. The Common Agreement is the trust agreement. I kind of call it the TEF because that's the framework. And just to sort of reiterate what Zoe already talked about, when thinking about national frameworks like Care Equality, it's best to think about it as networks talking to other networks, systems talking to other systems. And the best example historically has been telecom. If you could only communicate with your friends on Verizon, your cell phone wouldn't be very helpful. But if you can call somebody on AT&T and T-Mobile, then the interoperability of your telecommunications is much, much greater. So I asked, why would Stanford or anybody go to TEFCA? And like most medical informaticists, the first thing I did was I plugged it into ChatGPT, and here are some of the reasons. You expand your ability to share information. You can improve patient care and treatment. You may reduce duplicate therapies if it's already been done elsewhere, and improve cost efficiency. But you don't need to go to ChatGPT. You can just go to the RC website where Zoe actually recommended, and see on the left-hand side some really important benefits to joining the Trusted Exchange Framework. And then I'll talk about it next. Once you pick a QHIN that you want to participate through as a participant, your Qualified Health Information Network, and we chose Epic Nexus, they also provide some really important reasons for why is it important for us, Stanford Healthcare, and other provider groups to be involved. Improve patient care, streamlining our ability to exchange with multiple endpoints without having to have different agreements, different pipes, essentially, for the technology. So lots of good reasons. Stanford has always been working, as long as I've been there, for 11 years, on expanding our secure health information exchange. I mentioned Metcalfe's law, which is another telecommunication law, which is that the value of any network is the square of the people, the number of nodes that you're connecting with, just like the telecom discussion about AT&T and Verizon. So we really want to reach a broad group so we can share information, particularly for the treatment use case. We've been involved in that work for a decade now, starting with our Care Everywhere, which is our vendor-supported health information network. We joined the eHealth Exchange, which is a national network that started back in 2010. We've been a part of that since 2014. We were early on in the Care Equality Framework sharing in 2016. We then actually expanded to a large statewide health information network, Manifest MedX, in 2018. We've actually started to work through what's called the Epic Payer platform to work on some of the future use cases of payment and operations, and we'll talk a little bit about that. And last year, we actually started to use the new FHIR technology to respond electronically to queries from the FDA about adverse events. And we're live with that, and we're doing that through FHIR today. As part of our initial work with the eHealth Exchange, we provided over more than 40,000 SSA disability claims requests entirely electronically and immediately. It's automatic. It's already built in. We are fully enabled with those fast healthcare interoperability resource APIs for the standard United States core dataset version 1 and hoping to expand that over time. We've automated our request for records everywhere. So if you show up at Stanford in the clinic, in the emergency room, in the hospital, we've already tried to get your record from elsewhere. And we have found statistically that almost every patient we see has a record from at least one other place, and 2/3 have 2 or more. And it really allows us to see a much broader record for the patient and understand who they are from a health perspective in a much greater way. So extending reach is really important. We're looking for additional use cases. We're currently using Payer Platform for a small pilot, essentially with one payer, working on data sharing as well as medical prior authorization. And one of the things you'll see is that we are really excited to see additional use cases come down the pipe so we can actually expand that rapidly across multiple payers. We also really want to see how FHIR APIs expand, particularly into the payer space, payer provider communication space. So lots of good reasons for us to do it. So how do we do it? Well, first, you have to pick a QHIN. And right now, you can only have one. So every organization, every provider organization is going to have to select a QHIN. And you have to think about what's your technology platform? How do you actually know who you're connecting with? What's the security around that? And we made the decision to use Epic Nexus because it is our foundational health information platform, health information exchange platform. And we really have enjoyed the benefits that we get from them about managing the directory, certificates, security, and safety. Plus, for our providers, it's integrated into their clinical workflows so that they can see that whole record more easily. In fact, when our providers log into our electronic health record, they can look at encounters not just that we've had, but anywhere where we've been able to bring in that data. We share labs that way, notes that way, and patient and providers can see all of that about the patient, whether it happened at Stanford or it happened elsewhere. So you have to pick your QHIN, you sign an agreement, it's a legal agreement, and as a participant, there are, as Zoe mentioned, flow-down obligations. So you have to know what those are. You have to read the QHIN technical framework, the operating procedures, and understand what you're responsible for. And then we had to sign an agreement with the Epic Nexus QHIN to say that we will meet those obligations, and required a significant review both from a technology and security perspective, but also from a legal perspective. So once we selected our QHIN, our vendor QHIN was fortunate to give us this little checklist. And we followed the checklist and we configured our electronic health record system to support the new TEFCA framework. We had to establish some additional connectivity pieces. There were some technical pieces on our servers that had to be changed. And then we had to work on that directory and the certificate installation. And that all took place in December very rapidly. And we've been live as one of the first participants on the Trusted Exchange framework. Now, I mentioned we wanted to extend our reach. This is very, very early data. There are just a few people joining the framework, but within just a few weeks, we've been able to exchange hundreds of records with endpoints with other places that we were never able to connect to before. Verda Health is a company that provides management of patients with diabetes and obesity. They are part of the Health Gorilla QHIN, and now we can get records and share records with them, both sent and received, where we couldn't before. So already, TEFCA, in just the first few weeks, is starting to allow us to share records with other organizations that we could not connect to before without having to go to them directly, set up agreements, and set up the pipes to connect. RxLive and Kanza are two other examples, and we're excited to see more. So more connections, greater use cases, expansion of the use of FHIR, and we're really excited about the prospects of TEFCA. And the last plug I'll say, if you're a provider organization and you're not on TEFCA, get on TEFCA. It's time to start. Thanks so much.
Thank you so much, Dr. Eisenberg. And you teed us right up with the conversation is, we're looking at enabling nationwide sharing. We really have to focus on our intentional approaches to reaching some of those smaller and rural healthcare practices, right? So getting on that, how are these smaller practices getting on TEFCA? And so we're going to switch to Tina. Can you tell us a little bit about Veradigm and the work that you're doing on focusing on reaching these practices and the insights to need that we need for future iterations?
Yes, thank you so much, Rebekah. Hi, everybody. I'm here representing Veradigm, and at Veradigm, we're focused on research, analytics, and scalable data-driven solutions for all sorts of healthcare stakeholders, including providers, patients, health plans, and life sciences companies. Today, I'm going to talk about how we think TEFCA will help benefit some specific cohorts of ambulatory practices. So specifically, there are 3 groups that I've been focused on that I think are going to get the most benefit out of this network once we have everything up and running. And those are very small practices, 1 or 2 docs who haven't had the ability and the funds to invest in point-to-point connections or joining some of these other organizations. The other one are independent physician practices that do not want to join a larger health system, but want to remain fiercely independent. Now they have the ability to exchange data with all of the different specialty practices and hospitals that they want to send their patients to. And the one I'm going to focus on today is about rural healthcare. So we're going to talk and dig into this a little bit more because at Veradigm, we have a really unique position with practices and providers all across the nation using 2 different solutions. So I want to start us on just what is rural America, and the 2020 census really defines rural as anything that is not urban. So we have to look at the definition of urban to understand what is rural. And I went through a number of different definitions to think about how we would look at our customer population by this metric. So I put some definitions in here. There is a definition of urban that goes through this thing called a ZICTA, which was new for me, which is really just an area that could encompass multiple cities or zip codes. It's a region. It was a little difficult to translate that to the demographic information we had on our patient populations and our provider populations. So then I looked to, okay, we can tell where they are. We have addresses. The Federal Office of Rural Health Policy is a great resource when you're looking at this, and they identify 295 counties in the United States that are eligible for their funding. That also was a little difficult since I had addresses and not necessarily the counties, offhand to look up. But zip codes became the thing that was the easiest to do, to break up and take a look at the demographics. And I loved doing this research. As you can see from some of this data, the Federal Office of Rural Health Policy identifies over 19,000 zip codes that are identified as rural. So about 49% of the zip codes in America are considered rural, but only about 20% of the population lives in those regions. And you can imagine, these are beautiful places, expansive, lots of land, lots of sky. And I wanted to dig into our customer base and understand, okay, who's in these rural communities providing really critical health services to people, annual wellness visits, care that is going to be with them when they, when they're first identifying a solution and they haven't been referred to a specialist, et cetera. So let's take a look at one of our solutions, Practice Fusion. Now, Practice Fusion will really epitomize Big Bang when it comes to TEFCA because it is a cloud-based solution. It was initially designed and built in San Francisco, California. And what we found is that, of all the practices we looked at, this is a really easy solution to onboard and use. It offers a free trial. You get immediate access. You can be setting up your practice and seeing patients in a matter of minutes with online tutorials all by yourself. It's really simple to use. The average practice size is about 1.8 physicians. So it does ramp up. There's 500 or 600 customers that have over 5 physicians, but most of them are smaller. And we looked at over 20,000 active practices representing over 35,000 providers in America. And what we found was that the licenses for this solution were distributed across 7,200 different unique zip codes in the United States. But none of them were on that list of urban or of rural zip codes. So all of these are groups in urban or suburban areas where they have good internet connectivity. We're still digging into this. I've had a couple of groups say, well, I have a practice, that I believe I've identified as rural that's using Practice Fusion. So sometimes the definitions, we need to take a look at. But in our research, we didn't see anyone that was actually in a rural setting. However, the top specialties for Practice Fusion include family practice, internal medicine, and behavioral health. So we know there's a lot of people giving primary care to patients across the United States. One of the things that Practice Fusion does is we work with the National Association of Free and Charitable Clinics. And this is a really special group that has over 1,400 practices, mostly driven by volunteer clinicians, doctors and nurses, et cetera, that are serving a really vulnerable part of the American population, including people that do not have insurance and even undocumented migrants and immigrants. So this is a really important safety net solution, and about 30% of the practices, that are part of the National Association for Free and Charitable Clinics are using Practice Fusion. So we know getting access to TEFCA, being able to participate in this network, exchanging data is going to be really important for these groups. They do not have a lot of funding, and they don't have the ability to go out and establish point-to-point interfaces to get some of this data, but it really could help improve healthcare from that standpoint. So for Practice Fusion, we're going to focus on these smaller practices. We're going to focus on the groups that we're, providing free licenses for through this association and this network, and see what we can do to really improve healthcare across the board for everybody using that solution. Another example of solutions is our Veradigm EHR. This was previously called Professional EHR under the Allscripts brand, but this is a different type of solution. And I think our two EHRs kind of give you an idea of, we've got cloud-based, very easy to install. Everybody gets updated at the same time. Veradigm EHR is a little bit different path. Our users can have an on-premise server running this solution that they maintain and manage and update and control. They could be running in one of our data centers. They could be running in one of our cloud hosting solutions. They could have a third party hosting the solution. It's really flexible in terms of how the solution is and what kind of environment it's being used in. And so that means that clients get upgraded at different times. So we can control everybody in our hosted environments, but we work with the practices when they are updating their own servers or working with a third-party data center to update. So for them, it's going to take a very structured kind of rollout. We're going to have to track and measure and monitor and make sure everybody's getting the upgrades so that they can have access to this functionality. Some of these clients have been with us for a very, very long time, using the solution for over 25 years. So they've been through this entire, change, from high tech to meaningful use to cures. They're used to upgrading functionality for compliance and to get new functionality, but they do take it at different, steps and stages based on their own staffing and their own ability to support and upgrade. For this group, the average size is about 7 providers. And when we looked at the data here, these clients were distributed across 1,198 unique zip codes. And one thing I loved about looking at this is that our Veradigm EHR client population really does represent America really well. I'm going to show you a heat map in a minute, but 21% of the customers are in a rural zip code. So we get a really nice snapshot and ability to look at how TEFCA is going to interact across a really interesting representative group of American physicians and their patients. So I'm really excited to see how that plays out. But just to show you a little bit more of what that looks like, here's a heat map that we put together. These are only the clients in rural zip codes. And you can see across the United States, just like our population, we've got a lot of practices clustered in the Northeast, the Midwest, and the South, with West being, very expansive. And usually this purple flag is going to designate there's only one practice in that zip code that is using our solution. Typically it'll be a family practice, or in some cases cardiology is something that we'll see. But these are pretty spread out and across the entire United States. Now, one thing that caught my attention is kind of a cluster in northern Alabama that I'm going to zoom in on a little bit further. So you can see here near Huntsville, Alabama, we have this cluster of practices. I took a little turn on Google Earth to see exactly what this looks like because I've never been there. It's beautiful, right on a river and a lake, and there's all sorts of like lakefront homes, but there are lots of practices using our solution here. At one point, there's 5 practices in one zip code, 3 practices in a couple of these others. So we're going to be watching this area really closely to see how they adopt TEFCA, how that impacts their patient, satisfaction, how it impacts their administrative ability to get documents and data where it needs to go for their patients. And I'm excited to follow this journey along. So we're still at the beginning. We'll be focusing on implementation, education, making sure practices understand exactly what kind of functionality they now have. Many of them have questions. They have questions like, okay, do I still need a connection to my local HIE? Do I still need point-to-point connections? Does this replace or complement a lot of the different solutions I might be using today? How do I get this connected? Where do I click? How does it work? How do I know if I have everything? So there's a lot of work to do to educate and make sure that everyone understands what kind of data they're getting, where it's coming from. And the faster we can build this network so that we have 100% coverage across the United States, the better, because until we do, there will have the potential for data elements that are still missing. And one more thing I wanted to throw in, I do think that TEFCA has a huge opportunity to help foster innovation in health technology. So a lot of the groups I work with, they are establishing integration with our EHRs via either a proprietary API or FHIR. But just yesterday, I talked with a group and, was digging a little bit and learned that this third party that's focused on providing value-based care solutions for rural health practices, in order to get all of the documents they need and really take care of their patient population, they connect with 78 different EHRs, 22 state HIEs, eHealth Initiative, Commonwealth Care Quality, SureScripts, LabCorp, Quest. They call radiology centers for images, and they call hospitals when they have no other way to get information and no digital connection. So we have care navigators, we have people out there doing this work right now. I think that the administrative benefits of having the TEFCA network and having all of this data flowing kind of organically behind the scenes without a human having to touch it is really fantastic, and could give all of these groups a lot more time back to focus on other important things that they need to do in the practice. So Zoe, that's all I had for today. Thank you.
Thank you so much, Tina. This has been great, walking from the policy level down to kind of the academic institution that we would say would be rich in resources, to now learning about some of our other populations that may have lesser resources and have our vulnerable populations. And so I want to take that a next step down as well. As we continue to have this conversation, it sounds like everything's flowing and interoperability has been taking place for a while. But I want to highlight the human aspect of healthcare and the impact that health data sharing can truly have on individuals and their families. And so today, our last panelist, we have Dr. Brigman with us. And again, we want to thank you for your willingness to share your family's personal experience. But could you share Monet's story and, highlighting the involvement of health data sharing and the clinical decision-making in her care?
Yes, thank you, Rebekah, and I'm so honored to be a part of this panel. I'm learning quite a bit, and I thank all of you for the work that you're doing to try to improve the communication of medical records between providers. My name again is Juanita Brigman, and I'm the parent of Monet, Dailey Hoxer. You can see the pictures there of my beautiful daughter. And in that middle picture, you can see she's holding a picture of, I believe that would have been her first, ultrasound of the baby. So she unfortunately had an untimely death on May 21st of 2000, I'm sorry, May 19, 2021. And unfortunately, in her case, a lot of her medical records were transferred from her medical provider here in Georgia to her provider in California. But somehow the information related to her history of blood clots seemed to be either overlooked, or maybe it was never even noticed from the beginning. Just to give you a little bit of background, my daughter, she was newly married, had just moved from Georgia to California. 1 year into her marriage, she learned she was pregnant with her first child. And of course, we were all excited, but at the same time worried, because we knew the medical history. She had a history of blood clots. And she was told by her provider here in Georgia that if she were to ever get pregnant, that she would need to be on an anticoagulant or blood thinner for the duration of the pregnancy. When she moved to California, of course, she made sure her records were transferred to her California provider. All the information was there. She even verbalized her history of blood clots. But very shortly after she learned she was pregnant, she started experiencing symptoms. She went to the doctor on several occasions, complaining of pain in her, initially in her right foot. But that was dismissed as symptoms of the pregnancy. Mind you, she was only around 10 or 11 weeks at that time. So for it to be symptoms of her pregnancy, that was a little suspect. But she trusted the doctors. And from there, she kind of went on and just tried to do different things to relieve the pain. And then went back to the doctor with complaints of pain in her lower right calf. And again, it was dismissed as symptoms of the pregnancy. And again, they have her medical records, but for some reason, no one's accessing the record to see what else this could potentially be. And then on her last visit to the doctor, day before she passed, she went with complaints of shortness of breath. And again, she was dismissed. She was told it was, again, symptoms of her pregnancy. And unfortunately, despite 19 different providers who at some point had contact with my daughter and had access to her medical records, not once was an appropriate intervention administered, which unfortunately led to her death. And it left me with questions like, did the doctors or the nurses really read her medical history? Did they take her medical history seriously enough, at least? Did they even take her seriously as a patient when she presented with pain, or was she just simply dismissed? The National Institutes of Health and study showed that because medical providers often are less likely to identify pain in Black faces, they tend to minimize their complaints, and so they don't see the pain on a Black patient's face the same way they do a non-Black patient. So I wondered about that. Did her race, her age, or socioeconomic status impact the level of care she received? And of course, I questioned, how did she become among the 60% of preventable deaths, maternal deaths? It just could not help but wonder if, because they did have her information, that race and socioeconomic factors actually played a part in that. So, one of the things that this situation has motivated me to do is to become an advocate. As Rebekah mentioned earlier, I have to be an advocate for people who look like my daughter, who may not necessarily know the right questions to ask, or even to have the boldness to question the decisions of providers to maybe withhold a certain course of care. In my daughter's case, it was very clear that she needed to be on an anticoagulant from the beginning of her pregnancy. As soon as it was learned that she was pregnant, she needed to be put on something right away. So why doctors questioned what the next step should be was a big issue for me, because it was already there. It was already in her records. So I think that, educating our loved ones and letting them know that, whatever your condition is, if you're not feeling comfortable with what is being shared with you or communicated to you, maybe this is a case where you would want to seek out the opinion of another provider, not being afraid to do that, or not being intimidated to ask those questions, but more importantly, just educating yourself about what it is that whatever medical issue you're dealing with, to educate yourself, so that when you are talking with doctors, you have that confidence to question, or to say, well, based on what I've read, this is what I understand, or based on advice from my prior doctor, this is what I'm being told I should be doing at this stage of my care. And I think that lack of confidence and just a trust in the healthcare system is what allowed my daughter to go as long as she did without appropriate interventions. And not to put the blame on my daughter at all, but just saying, because the healthcare system should have not only just received the information, but acted on the information. And I think that that's where the fallout happened for her. So, definitely something that we struggle with every day. We hope that no other parent or no other woman has to go through the loss of life because someone failed to read the records.
No. Thank you so much for sharing that story. Like I said, I really wanted to humanize this conversation, because it surfaced, it sounds like we have records transferring across the nation, and everything is where it is, but we really need to bring it down to that very basic level that says, yes, sometimes the records are there, but are they usable, right? How are they presented to the clinicians on the other side, to where they do have 200% of patients that they over their quota for the day, but how are they using what they have in front of them to really move forward? And so I really appreciate you sharing your story, and very timely, as we know, maternal mortality in the United States is continuing to rise, and it is truly a public health emergency. And so we understand the importance of having the patient involvement and advocacy there. And so we appreciate your time in that. But also on the other side, what can we do better as health systems and as politicians to really ensure this? And so that cues us as closing out. That is a portion of my research here at Stanford, is to kind of continue this conversation and really look at interoperability and maternal health kind of moving forward. I'm using this specifically in some of our populations that may be vulnerable, as we know that 49% of US pregnancies are paid for by Medicaid. So I am looking at federally qualified health centers within the District of Columbia, Maryland, and Virginia area to look at, as we have this public health emergency, how much is the sharing of information really contributing to this, as it did in Monet's story, and how we can further that. So again, I want to thank everyone for joining us today. Please reach out to myself or any of our speakers. They have done a phenomenal job. I learned something each time. I speak with each of them, and always recentering myself around Monet's story, who I did know personally, who is family of mine. And so really want to support Dr. Brigman in this charge, and ensuring that we continue health interoperability conversations across the nation. So again, thank you, everyone. Happy Valentine's Day. And we look forward to continuing this conversation on our social media networks.